Hello again. So this is the chapter 41, drugs for PUD, peptic ulcer disease. The chapter begins or starts with the few slides as a review for the EMP of the GI tract, and then we'll begin with the clinical manifestations of the GI tract dysfunction. So the anorexia, vomiting, nausea, retching, these are the most common manifestations of the GI tract disorders or diseases. Projectile vomiting, that is the spontaneous vomiting that usually does not follow the nausea or retching. And the projectile vomiting, usually it's a sign of the obstruction in the GI tract, or sometimes even patients with the pyloric stenosis. With the stenosis of the pyloric sphincter, they develop the projectile vomiting. Constipation, which is defined as an infrequent or difficult defecation. And here are some of the pathophysiology or the factors or diseases that are associated with the constipation. Diarrhea, so that's the increased frequency of the bowel movement, and we have different types of diarrhea. So the first one, which is osmotic diarrhea, that is the non-absorbable substance in the intestine draw the excess of the water into these intestines, and that will increase the stool weight and volume and result in the large volume diarrhea. Now, the causes would include here a lactase and pancreatic enzyme deficiency. So when the lactase is absent, when the pancreatic enzymes as well also deficient as well, that will result in this type of osmotic diarrhea. Sometimes excessive ingestion of synthetic sugars, full strength tube feeding formula, like patients on total parenteral nutrition, TPNs, patient who had developed a dumping syndrome after the resection or surgical removal of the stomach gastric resection. The second type is called secretory diarrhea. And usually this type results from the toxins of the microorganisms, especially the bacteria, the infectious causes, bacterial toxins, and they will produce this type of diarrhea. So the small volume diarrhea with this type is usually caused by inflammatory disorder of the intestine. So it's the inflammation, and it's like, for example, patients with the ulcerative colitis, Crohn's disease, TBI, the patients with the Crohn's disease, ulcerative colitis, the inflammatory bowel disease, IBS or IBD, inflammatory bowel disorders. These may result in this type of diarrhea. And then the last one, which is motility diarrhea, that's usually causes would include the resection of a small intestine, surgical bypass of an area of the intestine, or fistula formation between loops of the intestine. Hyperthyroidism sometimes result in this type of motility diarrhea. Hyperthyroidism due to the increased thyroid hormones, because they will result in excessive motility of the intestine. Even patients with diabetes, they develop something called diabetic neuropathy, and then they tend to develop this disease. And also patients or individuals who would abuse the laxatives. The abdominal pain, so parietal pain, visceral, referred pain. So we have a few examples for each, like, for example, the parietal pain that will lateralizes, because which means that it will be at one side. The because the peritoneum is innervated from only one side of the nervous system. So patients may experience this as like one side pain, pain experience with parietal pain. With visceral pain, the pain arises from the stomach, for example, or is experienced as a sensation of fullness, cramping, or of the mid-gastric area. Referred pain, and that's, for example, the patients with acute cholecystitis, they may experience the pain to be referred to the right shoulder or scapula. Referred pain develop as the intensity of a visceral pain stimulus increases. Nausea also is another sign or manifestation of GI disorders. The common symptoms of vomiting are hyper salivation, so the excessive saliva production or secretions, and tachycardia. That's the most common symptom of vomiting. Retching, which is non-productive vomiting, and then the GI bleeding. So we have upper GI bleeding, upper gastrointestinal bleeding, like the esophagus, the stomach, the duodenum. The lower, that's when it affects the bleeding from like jejunum, ileum, colon, rectum. And then dysphagia, which is the difficulty swallowing. We have either mechanical obstruction or functional obstruction. So the dysphagia, either because so for example, the mechanical obstruction, which is the obstruction of the esophagus, or dysfunction that will impair the esophageal motility, like when there is a tumors, strictures, herniations that will obstruct mechanically the passage of the food through the right esophagus to the stomach. The functional that will be caused by nervous system, like neural or muscular disorders, like patients with a CVA, stroke, and they will have develop the dysphagia. Parkinson's disease, and then they develop dysphagia, or achalasia, which is the increased lower esophageal sphincter muscle tone, and that will result in the loss of peristaltic function, which will prevent food from entering the stomach, which is the right side of the slide. You have a picture or figure of the achalasia and the definition of achalasia as well. So the achalasia, again, that's the denervation of the smooth muscle of the esophagus and the lower esophageal sphincter, LES. A form of dysphagia characterized by the loss of the esophageal peristalsis. So the disruption or disrupted innervation of the smooth muscle of the and the esophagus, the loss of peristalsis, the lower esophageal reflex, sphincter, which is a cardiac sphincter, relaxation that will result in a failure of the LES or the lower esophageal or cardiac sphincter to relax, or a decreased relaxation of this sphincter will, after the swallowing, will allow food to accumulate above the obstruction. The decreased relaxation of this sphincter after swallowing allows food to accumulate above the obstruction. So the gastroesophageal reflex, which is the reflux of the chyme, which is the acid and pepsin from the stomach to the esophagus. And then we have the hiatal hernia, which is the protrusion or herniation of this upper part of the stomach through the diaphragm into the thorax. I know there are two different types of hernia. When there's a herniation of the GI tract and protrusion of that through the stomach through the diaphragm into the thorax, into the thorax cavity. All right, and sorry. Now, the disorders of motility, and we said just going back to the herniation, in which that we said that the herniation, which is the hiatal hernia, the sliding type, which is the most common type, in which that the stomach slides or moves into the thoracic cavity through the esophageal hiatus. That's most of the time congenital disorder. Coughing, the bending tight clothes, sometimes ascites, obesity, pregnancy may accentuate the hernia. So these are the factors that may accentuate the hernia: the tight clothing, bending, coughing, obesity, ascites, and pregnancy that may accentuate this type of hernia. The paraesophageal hernia or hiatal hernia, which is the great curvature of the stomach hernia through the secondary opening in the diaphragm and lies alongside the esophagus. So the symptoms include congestion of mucosal blood flow leading to gastritis and ulcer formation. So here there is some strangulation, which is the twisting of the GI tract. In other words, that the twisting of the herniation or of the hernia, that's the major complication, because always when there is a twisting, when there is a strangulation, there is a cut blood supply, and that may lead to ischemia. And ischemia means the complete cut of blood supply and the death of the cells. So both herniations, or both types of hiatal hernias, both types, they tend to occur in conjunction with several other diseases, like esophageal reflux or reflex esophagitis, peptic ulcer disease, cholecystitis, which is the gallbladder inflammation, cholelithiasis, gallbladder stones, chronic pancreatitis, diverticulosis. These are some of the conditions which that you will see or expect that this or any, both types or each of, both, like either one, that will be present in any of these conditions. Pyloric obstruction, which is the blocking or narrowing of this pyloric sphincter, which is the sphincter between the stomach and the duodenum. And that's when the patient will exhibit and result in a projectile vomiting. That's the cardinal sign of pyloric stenosis. So it's the pyloric obstruction that can be either acquired or congenital. And PEDS, so if you, when you get to the PEDS scores, the projectile vomiting in PEDS means it's we have to rule out, but at least that's one of the significant signs of pyloric stenosis. The disorders of motility also include the intestinal obstruction and paralytic ileus. The ileus, which is an obstruction of the intestine, and the intestinal obstruction, either it's simple obstruction or functional obstruction. The simple one, which is the mechanical blockage of the lumen by a lesion, tumor, cyst. The functional, which is the failure of the motility, which is like paralytic ileus. Often that will take place or occur after abdominal surgery due to the anesthesia medications. So these are different types of the causes of intestinal obstruction, like intussusception, which is like telescoping of the blood of these GI tract with the intestines. Valvulus, which is more of the strangulation and twisting, and that will result in a necrosis. Acute and chronic gastritis. So chronic gastritis, that's the when there is an elevated level of gastrin, causes pernicious anemia, which is the vitamin B12 deficiency, would result from this because of the absence of the intrinsic factor, which is responsible for the absorption of the vitamin B12, or autoimmune disease, or H. pylori infection. It may or it can promote mucosal atrophy and tissue injury. That's in type A. And then we have a type B, that's the antral gastritis, the chronic type. And it's usually associated with the hydrochloric acid secretions, also pernicious anemia, and the presence of antibodies. So even you can add H. pylori here as a major causative factor. So it's really sometimes hard to differentiate between type 1 and type 2, but type A or A or B, as he affects the fundal area of the stomach, and B affects the antral aspect of the stomach. So peptic ulcer disease, that's when there is a lesion of in the stomach or a lesion in the small intestine. So either it's gastric ulcer or duodenal ulcer. We call that peptic ulcer disease. So it's include gastric ulcer and the duodenal ulcer disease, both, and it can go under the peptic ulcer disease. These are some of the associated factors or risk factors for the PUD. So in addition to these, also you can add advanced age, chronic diseases like emphysema, rheumatoid arthritis, liver cirrhosis, obesity, alcohol. So the primary cause of peptic ulcer disease is the H. pylori. So when there is some erosions, that is superficial, and when there is a true ulcers, that will be deeply affecting the GI tract. Duodenal ulcers, developmental factors, which said the H. pylori, toxins and enzymes that promote inflammation and ulceration.